Welcome to the TCTAP 2022 Session 4 CTO. I'm Dr. Eugene Wu. I want to introduce my co-moderator, Dr. Gerald Werner. He needs no introduction to you all. He's a master CTO interventionist. He's been in so many meetings. He's a good friend of APCTO. He's been in many of our meetings here. In fact, many of our panel here is also from the APCTO group. I want to introduce you to Scott Harding, APCTO Director from Wellington, New Zealand. And of course, Mato Haibara from Toyohashi in Japan. And of course, Dr. Pil-Hong Lee from Korea. And so we have two distinguished lecturers giving their live cases to us in this session, and we'll have a question and answer after that. So I'll ask Gerald to introduce the two speak cases to you.
Well, thank you, Eugene. Thank you to TCTAP. That unfortunately is again only as a web seminar and a web platform this year, but nevertheless, exciting cases, exciting lectures. I think a very educative program. The two cases today are taped cases, so it offers us a lot of discussion. Manos Prilakis will present second, and we will introduce the first case by Demetrius Campoliotis. Actually, both cases are post-CABG cases, but as is usual in US, not so much, I think, in Europe or in Japan. And the post-CABG cases are the toughest, and Dimitri will show us how to tackle. Please.
I'm going to talk about a case in a post-CABG patient, which is actually very common in US, and the title is What to Do When Grafts Fail. I'm Demetrius Campoliotis. I'm the Director of CTO and Advanced Coronary Therapeutics at the Morristown Medical Center in New Jersey. These are my disclosures. They're not relevant to this presentation. So brief history. 67-year-old gentleman, status post-OM1 stent in 2012, 3-vessel CABG in May of 2021 with LIMA to LAD, SVG to PDA, and an SVG to RPL. And we'll see actually this is an interesting situation where this SVG goes. For the last 4 months, he has been complaining of angina, class 3, and dyspnea on exertion. He underwent nuclear stress test, which revealed normal EF with severe, large, reversible anterior and inferior wall ischemia. He was on appropriate medications. His CBC and BMP were normal. Diagnostic angiography revealed LAD CTO, RCA CTO, patent left circumflex stent. LIMA to LAD was occluded. SVG to PDA was occluded. And the SVG that actually ended up going to an RV marginal was patent. So I'll show you the films. This is a bypass graft going to something that looks like an RV marginal. We have a bifemoral access. We use bifemoral access usually in post-CABG patients only. Otherwise, we use a combination of radial and femoral. And here you see from the left system that we don't actually see the proximal cap very well. And from the collaterals, we see some epicardial collaterals with fainting feeling of the diffusely diseased distal LAD. And this is another picture, which actually shows that maybe the proximal cap is not that ambiguous. The stent is patent in the OM1 back into the proximal left circumflex. And I will pause here for a sec to hear brief comments from the panelists as to whether they would have chosen to do the LAD first, for example, if they think that the case is appropriate for PCI, and what would their initial approach would be. Gerald or Eugene or anybody?
So do you have a RCA? What does the RCA look like?
The RCA was stump occluded. I don't have it just for the sake of time. And we could not see it filling via collaterals from the LAD. We see here maybe a collateral going from the AV groove left circumflex filling, and RPL. But this is all we could see at the diagnostic films.
Great. So maybe we can go, we don't have that many panelists. We can go down the list and just see what people would do. So shall we start with Scott?
Thank you. I mean, obviously, this is a very tough case. I think the proximal cap is unambiguous, so you can get started, but the difficulty is really you can't see the distal cap or much of the distal LAD at all, just some very faint filling by epicardial collaterals. So that makes it really tough, because even if you get going antegrade, you really don't know where your target is. And so I think for me, it would be trying to define the collateral to the distal LAD a little bit better. And then if we can actually get filling with that, see if it's possible to get retrograde through that epicardial, and then if we can get a wire up, use that as a target to go antegrade through. But it's pretty difficult to see from these films that the distal LAD at all.
What about highbrow? How would you approach this?
So in this case, so I want to see the cardiac CT, because the distal target of the LAD is ambiguous, undergrad approach is not so easy. And so if there is a very small occlusion at the lemma, so there is a one chance to the retrograde approach from the Rita to use. And so I want to see the RCA. So if there is it's possible to recanalization of RCA, so there is some collateral from RCA too already. So anyway, so this is very, very tough case. So that so before the intervention, so cardiac CT I want to see.
And Dr. Lee, what would you think?
Yeah, I really agree that this is a really tough case, and I really agree to Scott's opinion that this case, I think the first thing we have to do is to try to clearly delineate the distal LAD, to either use the integrate approach or maybe to have an option for the retrograde. I'm not sure with these images which is the main collateral, maybe the branch for the RV or other epicardial collateral. But if with deep review of the angiograms, if we can choose one any kind of epicardial collateral, then maybe it's better to first start to negotiate that collateral and use some microcatheter or things to clearly delineate the distal LAD and to start or decide the strategy.
Yes, that's a very good comment. I looking at it too, I feel that without retrograde, it's going to be very difficult. If I were to do antegrade this, I might go straight off with an Ibis, because usually with the lemma, the LAD is more tortuous after lemma grafting, so it's not going to be a straight shot. So maybe Dimitri, you can show us what you did.
Yes, so I didn't do a CT, and from the right, there was a very short part of a vessel, and there were no other collaterals. So there was no other way of visualization. I agree, I think, with Scott that the proximal cap is not that ambiguous, but the course of the vessel is. So, and it was an epicardial collateral, and I wanted to give it an antegrade shot first. So I started with a Gaia 1 actually, and Gaia 1 next, and I made some progress. I was following the calcium, then I switched to a Gaia 2 next, and here is where I was able to work my way antegrade. And I thought that I was in a good spot, but I wasn't 100% happy. If you pay close attention at the end of the retrograde filling of the LAD, maybe they're not dancing together. So in a situation like this, I always try to do, try, I always do a caudal shot. I call it the view that don't lie. And here, again, I don't know if it was tortuosity as it was mentioned, but it seems that the tip of the wire and the distal cap are not in sync. So I was faced with a dilemma at this point, what to do. Just for 1 minute, if one or two of the panelists have a comment, what would they do at this point with this position of the antegrade gear and those two pictures that you saw in cranny and caudal views?
Maybe we ask Gerald, since Gerald is here.
I think you probably have the feeling that you are in the lumen of the vessel, so it would feel more you would feel more confident if you would be sure that you are in the lumen, at least proximal. So anyway, you will have to dilate one point in time. So I would dilate, try to do Ibis, and understand how far am I in the correct lumen to prepare maybe for a parallel approach, parallel wiring. But for parallel wiring, you need to know where to deviate from the other course of the vessel. So I would do proximal Ibis imaging.
Okay, so I wasn't very happy with the position of my wire. I thought that I didn't think that I had exited the vessel, so it's reasonable to probably dilate proximally. But the wire was not moving smoothly from that point on. And given the potential for tortuosity, as was mentioned earlier, I didn't want to continue antegrade. So I decided to explore the retrograde options here. And you see that in order to delineate better the channels, I do a distal injection simultaneously with injection from the graft. And then I took a Shure 3, and with some luck, I was able to negotiate those epicardial faint collaterals. And I think here that the radiopaque part of the wire is going towards the distal LAD. So I felt good, and then I advanced my Carabel, and which is the microcatheter I use for epicardial collaterals most of the time. And then by pulling it slowly back and with a 90-degree 1 millimeter angle on the Sheehan wire, now I was able to navigate the Prox LAD to the distal cap. So essentially now I followed one of the recommendations of the panelists, which was to use a retrograde wire as a target for the antegrade approach. However, because it's an epicardial collateral, I thought that it would probably be my bailout plan should the antegrade approach fail. And this is, I think, a maneuver that we don't use that often, and we should. Distal tip injection from the retrograde microcatheter to understand a little bit better the distal cap, what branches are there, and have a target for where to puncture with a penetrating wire, most likely.
Why did you remove the antegrade wire?
Because I was a little bit nervous about the way it was moving. I didn't remove it correctly. I stayed within the proximal part of the vessel where I felt safe that I was in the vessel, but I removed it back and was going to go again having a retrograde wire as a target. Now I had more confidence, and I was able to get the antegrade wire and retrograde wire dancing together, dilating with the microcatheter. And then, as you see, I like when I have an ostial occlusion of the LAD to make the connection actually within the LAD using a guide extension. And this is a reverse cart. I think it was a 2.5 or a 3.0 balloon. Some people would probably remove the balloon, trying to get into the antegrade system just to make more space. I didn't at that point, so I had some difficulty entering, but then at some point I did pull back while I was working with my retrograde wire, and you will see in a few seconds that's a little bit of a long run, that I was able to get in the, you see here, I pull back the wire a little bit, and now you see the Gaia 3 next, which is the wire that I use most of the time to make the connection reverse card, is going into the Untitled guide extension. And then the Caravelle, and then obviously externalization. I usually use the RG3. I did dilate with a 2.0 balloon all the way down, but because I was very distal and I don't like to have gear in the cardiac collaterals for a long time, this is a dual lumen microcatheter in an attempt to switch from a retrograde system into an antegrade system. So I usually take it almost if it's a septal, I take it down to the septal and wire the distal vessel on the way back through a second wire from the central lumen, or I just take it as closely as possible. And then here you will see that I have a Shion wire trying to negotiate the mid-distal part of the vessel. This is where the collateral was coming in, and now I have ownership of the distal vessel. Then something very important, how to remove the retrograde wire. We never pull wires, bare wires, especially with epicardial collateral. So I re-advance in the antegrade guide extension. I pull my externalization wire and I change it for a much softer wire. Then I pull the microcatheter back, take it with the wire still across the collateral to make sure that there's no collateral damage. Here you see that it doesn't seem that there is, it seems intact. And again, I don't just pull. I go up again, I pull the wire, and then to the soft part, and either remove it as a unit or like you see here. So then it was just stenting. Again, another picture of the collateral without the wire to make sure that there's no injury. Ibis, which I will not show you just for the sake of time. Balloon dilatation and stenting. Here we can have some discussion at the end. The left main, although geographically looks suspicious, it was fine. So after wiring the circ, I just did something that I don't do that often. I didn't do a crossover stenting, but I kind of nailed the ostium, as we say. And this is the final result of the LAD. Diffusely diseased distally may be one of the reasons that the Lima graft has failed, which, by the way, it was not a short occlusion. It was one of those occlusions that they were about 30 millimeters from the anastomosis, with a lot of kind of bridging collaterals, very difficult to use it to recanalize. And now you can also see better filling of the right coronary artery, which could potentially be or will be a target for a staged procedure in order to fully revascularize the patient, especially if he remains symptomatic. And this is a caudal view to make sure that the left circumflex was okay. And obviously this was done Ibis guided. I do 100% of my CTOs with Ibis guided, with Ibis. And this was the final result of the case. And thank you very much for your attention.
That's a very nice case. I especially love the way you demonstrated each step of the removal of the retrograde system. That's absolutely fantastic. I think we should move on and have Manos' case, and we'll discuss both cases at the end. Is that okay? So I'll get Jared to introduce Manos.
Perfect. Yeah, thank you so much. And building on Dimitri's presentation, I will show you a case on a previous bypass patient that the theme of the case was actually uncrossable, and I will explain that in a few seconds. So similar to the previous case, it's an elderly gentleman. He does have previous coronary bypass, severe angina on 4 anti-anginal medications. And then he had bypass 9 years prior with 3 grafts, multiple percutaneous coronary interventions. And then he presented actually with a non-ST elevation myocardial infarction because of occlusion of the saphenous vein graft to the obtuse marginal. And we can see here, this is the native circumflex. There's an ostial LAD occlusion. There is a stent into the proximal circumflex. The obtuse marginal is occluded. This is a bypass, a vein graft that goes to the diagonal branch. That seems to be okay. The lima is actually okay as well. And then this was the problem here. This was the saphenous vein graft that goes to the obtuse marginal. There are some previous stents there as well. And actually those stents are going across the distal anastomosis. It took quite some time with thrombectomy and eventually balloon angioplasty, and eventually there was successful recanalization of that saphenous vein graft. So this was done at the time of presentation with non-ST elevation myocardial infarction. Sometimes you can actually do the native coronary, but this was considered to be a fairly complex procedure for the native. So he was left with this result and then planned to come back for trying to open the native coronary CTO. So here we're now, and this is the dual injection. We do have an amplets into the graft that goes to the obtuse marginal. Interestingly enough, if you can see, there is significant restenosis, tight mid vein graft lesion. And then this is the native coronary vessel. There's some left main disease. There is a stent that goes all the way across the proximal cap. So we don't really know where the proximal cap is coming. And then we do have the bypass graft that is filling retrograde. There's some disease in the distal anastomosis on both limbs, actually. Diffuse disease on the proximal portion of the obtuse marginal branch. And maybe we can take a minute here, and I would be, delighted to hear how people would approach this procedure.
So, any comments from our commentators?
Let's start from top. Scott, again.
I mean, again, it's an extremely difficult case because the distal axis has been jailed and the proximal cap's also jailed. So it makes it a sort of doubly difficult case. I mean, these are the worst sort of post-bypass cases to do when they've been jailed. So I really think, again, you've got to get retrograde access. Fortunately, the bypass graft is patent. We've got to get through the side of the stent, dilate that, and then advance a retrograde wire, and then see what progress you can make retrograde, and then you may have to try and make antegrade progress towards retrograde wire. But I think first up, I'll be trying to get across into the proximal part of that OM, and then see if I can make progress back into the circumflex.
I think the added problem is that there is no defined distal cap. So the distal cap has a side branch and no visible notch. And in my experience, when there is stents across a side branch, it's very difficult to identify that from inside the vessel, other than in a non-stented vessel. So Dr. Habara, what is your experience with these situations?
Yeah, so that's so I agree with so Dr. Warner. So that's so antegrade approach occluded stent side branch is very difficult to antegrade approach. So that's so at first so I started a retrograde approach with so vein graft, and usually so this pattern so guide wire go to the side branch. So that's also use double lumen catheter with Sasuke, and so direct retrograde approach, and guide wire so usually cannot penetrate to the stented antegrade lumen, but so that at that time I changed it to the antegrade approach, and so the retrograde wire is a target. And negotiated the antegrade wire to near to the retrograde wire. And at the CTO site, I will perform a cut, reverse cut or cut, because so we can negotiate it or retrograde balloon. So that's I can one choice is also classic cut technique. That is my opinion.
Dr. Lee?
Okay, so the situation is quite complex that the proximal cap is unidentifiable and it's crossed over by a stent, right? So my initial choice would be a primary retrograde approach in this case. And the great obstacle is that there's a stent there, and ultimately we have to use a very hard wire to cross it retrogradely. But the good part is that the stent acts as a safety tool to predict the injury of the circ. That's a good part. So if you imagine stumpless ostium at a DCTO, sometimes if we don't have any option, we just stent the circ and do a retrograde use a stiff wire to cross the LAD ostium stump to the left main. So this might be similar to this case. So I would like to use a retrograde approach primarily and use a stiff wire, maybe use an antegrade Ibis to guide the retrograde wire to the primary retrograde wiring.
Eugene?
Well, I'm worried about this because it looks like there's a huge chunk of calcium in the CTO body. So I think all of what you said is true. It's going to be a retrograde case, but I think we're going to have trouble because that CTO body looks extremely calcified. And he titles it uncrossable, so we're in trouble.
When I look now 10 times on this image, indeed, is there the calcium indicating the ostium? Manos?
You know, possibly, to be honest, I could not be 100% sure. There is this dense calcification that you can see proximal to the bifurcation of the distal cap. Probably, but you know, the calcium could be in the intraplaque, extraplaque, so it's hard to know exactly where. But I agree with you, probably it was where the vessel was coming off, where the heavy calcification was present.
So what did you do?
All right, so as everyone mentioned, you know, having no understanding of the primary, of the proximal cap, we decided to go with the primary retrograde approach. We put a wire into the circumflex, of course, for protection. This is a Sion black, this is a corset excess. Fortunately, it wasn't too hard getting retrograde with the wire. You can see the angle was actually favorable. But then we couldn't get the microcatheter through, so we had to balloon the distal anastomosis. Also, look at the tenting. There is a significant tenting of the native coronary, and that will come in play in a few minutes while I'll show it to you. But then we're able to get the corset excess retrograde and then tried with Pilot 200. You know, it made some progress, but then it seems to be now wrapping around the stents on the circumflex. So it looks like we're the subintimus last extra plaque space. And that was a challenge. We had difficulty getting the microcatheter higher up because of significant disease. So we did a balloon inflation with a 1.0 millimeter sapphire. And then we were able to get another microcatheter and advance it a little bit further back. But then despite using a Gaia, despite using a Pilot, you can see what's happening. We have the wire essentially just loop and be in the extra plaque space, but cannot penetrate through the previous stent.
Was the antegrade stent, the circumflex stent, underexpanded? Did you check by Ibis?
There was some disease there. Actually, if I go back, there was some disease. Now it's hard to know if it was neointima under expansion. On the Ibis, the stents seem okay, but there seemed to be some small amount of neointima, but there was some under expansion as well. You can see here the stent in the proximal circ is actually smaller than the vessel more distally. So at this point, we tried for quite some time with the retrograde wires, didn't work out. So we decided to maybe try undergrade. I think that was mentioned before from Dr. Habara about trying some undergrade wire and see if we can make it to match the retrograde equipment. We still didn't have any, we couldn't see the proximal cap as you mentioned, Gerald, there was no, we did Ibis, we cannot tell where the vessel is coming based on the Ibis, but we had the retrograde wire, so we took a Venture, which is an angulated microcatheter and provides very strong support, and then tried with actually fairly penetrating wires to try to get through Gaia 2nd, Hornet 14, actually try Gaia next to, couldn't get through. So any thoughts at this point? So we're having the challenge, we're there, but we cannot make the connection between the retrograde wire and the true lumen proximal.
I think somebody mentioned Ibis to see where the retrograde wire is in relation and directing it with an Ibis. That may be possible. Or else what Gerald was hinting at, which I think is that the proximal stent, if it's underexpanded, just blow up the proximal stent and then you have a big balloon inside it and then you can puncture into the balloon.
Yeah, you reduce the extra stent space where the wire could lose itself.
Perfect. So actually, we did not do that, but we went back and tried retrograde again. We got a new wire, and this was a Gaia 2nd, and actually the Gaia did cross, as you can see, interestingly enough. Eventually, by keeping the tip straight, we were finally able to cross, and the wire just went straight in and into the guide catheter. So at this point, we're obviously very happy, and we thought that the case was not done, but we're close, and that was a mistake. We could not get the retrograde gear to go through, despite putting a balloon on the undergrade guide catheter and trapping the retrograde wire. We just could not deliver a retrograde microcatheter through the previous step. So any thoughts about this problem now?
Chip in with a turnpike spiral?
We did that later on. But actually, it would not have worked here. Not the tip in, but advanced, as I will show you in a minute, it wouldn't have worked. But that's definitely an option. But what we did actually is we came back, and now you see we have a guide extension in. So we put a guide extension on the vein graft, and then we did more ballooning. So we did this is Sapphire Pro. We did the small balloon. Try to go as far down as we could, try to dilate the tissue, make more space for the microcatheter to go. And so this is an example where the retrograde, the wire goes, the microcatheter does not. So we dilated as much as we could. And then we did get more support. We did the guide extension. And then we actually tried a new microcatheter as well. And then we tried a new turnpike LP through the 6 Friends guideliner. And then we were finally able to get through it and advance it into the undergrade guide catheter, and then externalized with an R350. So at this point, again, we're feeling good. But again, maybe we spoke a little too soon. So now we have the same problem, but in the undergrade direction. So nothing will go through over the undergrade direction. We tried the Sapphire. We tried the threader, we did try a Takeru balloon, we did try a new microcatheter, did not work. So any thoughts about this problem?
I think you only have 2 options. One is that maybe the previous stent is very underexpanded and you really just need to blow that up big, then that will loosen everything up. The other thing, of course, if you trying to get through struts is to rotor it. I mean, that would be the other option.
Yep, no, great points. And I must say, the balloon, I think you mentioned it before as well, that would have probably been a good idea here because the vessel was the stent was not perfectly expanded there, so that might have helped with that. So we didn't do that, but we did try, again, new microcatheters. And then at this point, what we should have done probably is to use a laser undergrade. You know, laser can sometimes help you get through. But instead, we decided to do rotablation. We decided, you know, it was so hard to get through, maybe we should do rotablation. So what we did is we advanced again a retrograde microcatheter. You can see the retrograde actual microcatheter was able to get through. And then we decided to go to atherectomy. So skip the laser step, which retrospectively was a mistake. Now, one of the things that I forgot to mention earlier on is that for logistical reasons, when we started, we did not use 90 centimeter guides. We actually used standard 100 centimeter guides, and that was a mistake. That was a problem that came to haunt us, as you will see. But in any case, we were able to get through from the retrograde microcatheter. We got the roto wire in, and then we were advancing the roto wire, but we could not really advance it anymore. The wire got stuck over there, just couldn't move it at all. So we ended up having to snare it. So we went in with a small snare. This is a 2.4 millimeter in snare. We got the wire, and eventually we externalized it. But then I think because we just had the long guides in, we had very little wire. And despite doing trapping, we could not actually get the rotablator in. So we ended up, essentially after trying for quite some time, we ended up giving it up. We came back out and we decided to just re-snare and start again. But to cut the long story short, we lost everything. So we are back to square one. We lost our wires, and now we're trying to go there again. And maybe because we had worked on the lesion hard before, it was actually fortunately not too hard. This is a retrograde gladius wire. And you can see here, it actually went fairly smoothly, fortunately, and crossed back into the true lumen. So we were able to get the retrograde wire up again. We externalized an R350 again. And this time, for whatever reason, the balloons went. So one of the hypotheses here is that maybe we were hitting some stent struts, something was in the way, and that's why no equipment would go. And maybe when we recrossed from a different strut, and that made things easier. But now we're doing well. So now we have the balloons, and we did serial balloon dilatations, 1.5, 2.0, 2.5, and now things look good. But we decided before we stent the bifurcation here now, the OM and CERC bifurcation, we decided we should probably first take care of the distal portion of the obtuse marginal so that we can remove the externalized guide wire. And we had a very hard time. You see the angulation here, the tenting. We could not get a wire to go undergrade to take this bend and go down. So just curious if any thoughts about how to tackle that problem now. So it's going undergrade, going through that tenting.
You can use a dual lumen catheter.
Yep.
You can use reverse wiring with a dual lumen catheter. Somehow you will make it.
Sometimes you might be able to push the wire down from the vein graft with a balloon as well.
Yeah, the excellent points. And we did do that. We actually first ballooned around because there was actually significant restenosis. So we went through the vein graft and we ballooned the anastomosis on both sides actually. And then the dual lumen didn't work. That was actually, this is Sasuke. Sasuke didn't work. So we tried to do the reverse guide wire. We got the loop up there. You see, it didn't work exactly well. But then for whatever crazy reason, after just advancing it, this was a Fielder XT, actually just went down. So sometimes it's better to be lucky than good, I guess. But eventually got it down. It was very tricky advancing the balloon. And this is sometimes when I do this, I take the retrograde gear out and that I lose everything. So I was very careful not to remove the retrograde wire so I can deliver stuff. And that was extremely helpful. It was very, very hard to get the stents to go through this significant bend. And then I had a similar problem with the stents, couldn't get a stent down. We finally used a different, smaller stent, and actually eventually the stent went. So there we are. Now we're making progress. We put another stent in the obtuse marginal branch. And now we decided to stent the bifurcation. And we decided to do DK cross. But I'm just curious what people would do here. What would be your approach in stenting this bifurcation? You see the angle is actually fairly tight. This is it's like 20-degree angle between the obtuse marginal and the circumflex. So any thoughts about how to take care of this?
Yeah, as the diameter is smaller than the main vessel, I think kind of a crush technique is the only option. It would be ideal to do kind of a tap right at the ostium.
Yeah, I mean, that would be an option. To be honest, I was very worried about TAP. And the reason is to do TAP, you would have to remove your retrograde gear, right, and rewire. And that can be, you know, could be, given the trouble we had here, I was very hesitant to give up my wire position. So we decided to do the DK crush so that we maintain access to the main vessel and then have access to the other vessel as well. So we placed the stent first in the side branch. That was the hardest part. That went out well. It was crushed, which worked out well. And then rewiring was actually fairly easy. And this is the first kissing balloon inflation, 2.5 balloon in the obtuse marginal, 4.0 balloon into the circumflex. And then we stand it into the main vessel all the way from the left main down in the circ. This is a 4.0 stent, 4.0 by 38. And now, unfortunately, now we have a similar problem. We cannot now get an undergrade wire to recross into the obtuse marginal. I think for whatever reason, again, we had a very hard time. We did use the Sasuke there again. We did use a wire with a loop to avoid going under struts, but we just had a very hard time crossing into the side branch. So any thoughts about how to solve this problem now?
Well, you should have left the retrograde microcatheter in position.
The retrograde is there. It's not easy to recross the retrograde though.
Yeah.
Okay, so you're saying just go retrograde and do this again, right?
Yeah. Okay,
so again, we tried the Sasuke here, it didn't work out, and then we actually followed your example. Actually, it was fairly easy going back retrograde. So this is a retrograde. I think it's a Sion black, and you can see actually we looped it, and it actually went relatively easily all the way through that proximal bifurcation all the way back into the guy. So this is an example where DK crash, the recrossing is solved in the retrograde direction. We did have a hard time actually getting the microcatheter to get through. So we tried the turnpike LP and that did not make it through. And then we tried the fine cross and that did not make it through. So at this point, any other thoughts? So we have the retrograde wire, but unfortunately no retrograde microcatheter can go. And
can you do a tip-in at that point?
So exactly, and that's exactly what we did. And I must say, I was a little, we did trapping to get more support, but didn't work out. And, you know, the wire was actually a little deformed here. You see, this is a retrograde wire, it was a little deformed. So I was really worried where it was going to work. But on the first attempt, literally, just get the undergrade corsair and literally just went right through, right on it. And, you know, fortunately, it actually advanced fairly easily all the way down through the bifurcation. So we had no problem crossing with the undergrade microcatheter, remove the retrograde wire, and then advanced an undergrade wire. And then after doing that, did the second kissing balloon inflation. And the result was good. We still had some competitive flow from the Saphenous vein graft. I know this is something that is debated about whether you should do something to the graft or not. This graft did have a significant stenosis, so probably it would close spontaneously over the next few weeks or months. Anyone would close this graft? Would you just let it be, or?
Well, I haven't done coiling of the graft. The better guy wins. If you still lose the vessel after with a stenotic graft of that age, I think, and there is something wrong with the flow.
Yeah, that's a good point. And to be honest, again, it's controversial. I mean, we do tend to work more on closing the grafts. We had a couple of cases a long time ago where we had some stent thrombosis from this. So anyway, and this took literally 5 minutes. So we put 3 coils in the graft and that occluded the graft. And then we did have some nice flow down the graft there as well. So again, it worked out well in the end. Again, a lot of troubleshooting. But eventually we did have a nice result, a good result in the circumflex as well as the obtuse marginal, and there's no longer any competitive flow. So again, multiple troubleshootings here, but the biggest problem was crossing. Crossing retrograde was a problem, crossing the microcatheter was a problem, crossing DK crash was a problem. That's why we call this uncrossable. But again, various techniques were available to solve some of the problems.
Yeah, well, that was really a bag of presents, or how you call it in English, surprises. But there were two things. This was fantastically managed, and probably how long? 3 hours, 4 hours?
This was a long case, but it was in the range of 4 hours or so.
Yeah, I generally only work with 90 centimeter catheters. So the case cannot happen except when the patients are very tall. In Europe, in US, probably you also have tall patients that the catheter doesn't fit. But 90 centimeter is the routine because of these problems when we go a long way around long collaterals. And still, I think having dilated the circumflex from the beginning would have made things a little bit easier or changed a little bit. But, well, it's a fantastic case. Any thoughts from the panelists to Scott, to comments to this case?
A fantastic case and a real tour de force to get through that. And I think it just shows that really to do these sorts of CTOs, you really have to have multiple techniques, clear understanding of the various algorithms that you can work your way through when you get stuck at various points, which Manus illustrated in his case very, very nicely. I think it's essential if you're going to get through a case like this. I'm just a little interested. Did you Ibis it, Manus, at all?
Yes, we did Ibis at the end and check the circ, check the obtuse marginal. The expansion was good. There was actually, I think what we didn't really appreciate as much earlier on is there was significant disease in the circ. So the stent was not perfectly placed, as Gerald was saying. And that, as you say, probably played a role in the expansion. At the same time, my concern was, I guess, earlier on, if you start putting balloons there, would you make it harder to cross the retrograde? I mean, so I don't know. But in the end, it expanded very well with the new stent, 4-row stent and 2.5 on the one.
I guess just my second comment on this case is that, you did a DK crush, which obviously worked out very well. But my preferred mechanism for this sort of case is a culotte. But you've had a big discrepancy between the sort of the sizes of the branches, which wouldn't really allow that. But the culotte works out quite well in this, and much better than a tap, because a tap with that acute angle really isn't a tap.
Any more comments?
So I have a question more than a comment. So in the old days, I think the older people among this group will remember we used to externalize rotor wires because when I started Retrograde back in 07, 08, I remember I sent an email to Dr. Kato and says, what should I use to externalize? And he says, rotor wire. So I remember doing a lot of externalization with rotor wires, and it usually takes 20 minutes of pushing, and your fingers were hurting and bruising. So I never really, nowadays, when we have RG3, it's very fast. So nowadays, I never do retrograde externalization or rotor to rotor adhesion. I always try to use a tip-in and then use an antigrade to wire it. And even if I have to give up the retrograde wire, I would try to wire with the rotor wire antigrade, or do an antigrade rotor tip-in to the retrograde microcatheter, because I find externalizing just too painful. So I'm interested to ask, anybody on the panel, do you, if you rotor lesion, do you prefer to externalize a rotor wire, or do you go antigrade?
So I have never experienced from the rotor wire from the retrograde. So yeah, so that's so at the same situation, I have some many experience, but one choice is rendezvous technique from the retrograde wire inserted antegrade microcatheter and advance the microcatheter as possible. And at the time, they put the retrograde wire and anyway try to cross the antegrade rotor wire. And if cross it, so at the time that's a rotor ablation will be performed. Anyway, so retrograde rotor wire I have never experienced.
Actually, I agree with you, Eugene. That's a great point. There are some reports, actually Roberto has done a couple of cases where they did rotablation. I think Dimitri has done some too over the RG3. I know it's not designed for this, but you can actually do rotablation over the RG3 wire. Actually, we don't have RG3 in our lab, we have R350, but that might have been another option here, doing the roto over the RG3 instead of trying to externalize. But I think you're right, retrospectively, as you have tried to get an antigrade microcatheter down as far as I could, then get the roto wire to go, hopefully, and then do rotablation that way, that might have been the better way to go.
Yeah, I did the RG3 rotablator a few times, and then once I actually cut the RG3 wire with the rotabur. After that, I didn't dare to do it. I have one more question for Manos. You say when you put the rotablator down, it wasn't long enough to come out the wire, but the wire is externalized on the other side. So could you not just put a talker on the externalized side and just burr without the wire coming out of the rotabur? Is that possible?
Good question. I don't know. I don't know. I get potentially.
Gerald, have you done that?
You're right. Maybe we should actually retrospectively. You're right. Yeah, maybe that would have been an option because it won't spin. I just, mentally, I guess I wasn't prepared to run a rotablator without because I didn't know how much I had back, right? So is it safe to rotablate if you don't have the wire far back? I don't know, but you're right. Maybe that would have been an option.
Yeah, I think the problem is that you probably need some tension on the wire. If the wire's not coming out the end, and then you may end up getting sort of kinking and just cut the wire if you don't have the wire coming out the end to provide some sort of tension to go straight.
So maybe we ask, we have Dimitri's case discussed only briefly during the session. I think it was also a very elegant case with some small hints, like you mentioned the balloon and the guide liner. I personally think leaving the balloon at this position makes it much easier to get the retrograde wire in than removing the balloon. The balloon doesn't take away much space, but the balloon is a good rail, especially when there are bends to guide the retrograde wire into the guide liner. So I do this actually as a routine, always leave the balloon.
I do too. I just said that some people think that they should remove it. Eventually, what worked, I think, is that as I was wiring with my Gaia 3 Next, pulling a little bit the balloon back, maybe dragged the tip of the retrograde wire into the guide extension.
Yeah, but this balloon rails, I think this is especially helpful in the right, the proximal right, even without a guide extension, to kind of cover the top where the wire wants to go, and you keep it down. So this ballooning technique is very nice. And the removal, you mentioned that very detailed. I had a discussion recently with Eugene how to remove the retrograde gear with respect to his complication case. I have a different method. I always advance and fine cross on the externalized RG3 and then kind of protect the whole the whole system, and I let them connect. And with this approach, in case you have damage to the collateral, you have a microcatheter antigrade in position and retrograde to get into the collateral and deliver whatever method you want to seal. So that's something one could keep in mind.
So that's correct. I mean, I think I really appreciate Dimitri's very nice demonstration of this. I've called it in the paper that so many of us here are authors of the retrograde recross method, because you basically recross the retrograde microcatheter. And I especially appreciate the recross of the channel to protect it from the final wire pulling back. So that was beautifully demonstrated in that. So
if I can make one comment, sometimes if you leave the retrograde wire, you have a little bit of cleading, so to speak, in the vessel. So you may actually not see all the time the leak if it's there. It has happened to me. But obviously you have control of the collateral from both sides, as Gerald said, which is a plus. So you have to balance. You have to balance this. I also think that it's so basically what I do most of the time is I just remove my externalized gear, then put a soft wire, and I pull back. I have a softer wire, see the collateral better. Usually I do dual injections so that you can feel it from both sides and increase the chances of detecting a leak, and then re-advancing the microcatheter and then removing. So there are many ways to skin the cat. The bottom line is that you have to be extremely vigilant how you remove the retrograde gear, especially through epicardial collaterals. And this is one of the situations where I go to actually high resolution and high frame rate on my cine, because I don't want to miss. This is not time to save radiation. I think it's very important at this point to make sure that you had a safe procedure without a complication.
So just a question, Dimitri. One of the issues that you might have had during your case is that you're working through a dominant epicardial collateral to the LAD. Did you have much trouble with ischemia?
Actually, I did not. And I was surprised pleasantly. There were actually more than one. I did a lot of distal tip injections in multiple views that I didn't show you. But there was like a cloud of collateral. It was not. I didn't have ischemia, but it's very possible if you have one dominant epicardial collateral to actually have ischemia. And we had cases that we had to abort them because the patient were developing ST elevations or even throwing sallows of VT. So this is a very good point.
So Dimitri, what are you going to do with the RCA CTO in terms of the complete revascularization concept? Were you going to do it, or wait for time for a symptom occurs?
That's a good question. I think, first of all, I think that the patient should be fully revascularized. I know that there's not too much data, but he had a bypass surgery, which the intent was to have full revascularization. I will wait at least 6 to 8 weeks to let the collaterals grow. If you remember at the end, you could actually see the RCA. Maybe for the first time, and it's a pretty large vessel. And having the luxury of looking back into the angiograms when the vessel was open or the graft was open is very informative, because when the vessels are closed, you have no idea how big they are. So I will wait 6 to 8 weeks. I will bring the patient back. And then if I have a safe approach to do it, which I think I will through well-developed septals, then I will go for full revascularization.
So
yeah,
we have
I think
maybe I let Gerald have his comment, and maybe Gerald can wrap up the session after that.
Yeah, the final thought of Dimitri, of course, this highlights a little bit the paradox of complete revascularization of the PCI operator as opposed to the CABG operator. The CABG operator never asks which bypass is the main important graft for the patient. He grafts everything. Once we start revascularizing, we should ask every step of the way whether there's still ischemia, which I think is paradox. When there is ischemia in the beginning, we should, as you will plan to do here, do a complete revascularization and not re-evaluate the patient in between. Other than it would be a very small artery. So I would completely agree to go ahead here. So I think we saw 2 cases which are probably the toughest because CABG patients are always a special type of lesions and pose additional risks. And we saw 2 ways of dealing with the CABG situation. You must be very versatile, know all your tricks and tools, and that was nicely demonstrated. I thank Dimitri and Emmanuel Manos for their cases and the lively discussion by our panelists and by my co-moderator. And I hope the audience will enjoy this session and enjoy the whole program of TCTAP. Thank you all.
Thank you all.
Wonderful. Thank you.
Thank you.
Bye.